Well, thank you, Dr. Brower. It is a privilege to be here to address such a distinguished group of people, the Lord's anointed here in the North American division, and the work that they're carrying out. I'm fully aware that I am only a part of the right hand of the body, and I'm very aware of the import of this presentation on such a wide number of people. What I'd like to do is to start off a little bit with an update on COVID-19. And I want to particularly focus on three different areas. Number one, I want to focus on the overall course of the disease. And in that, I want to emphasize how there are two different aspects of the disease, both the early and the late. And then I want to talk a little bit about vitamin D, which I believe is probably one of our best shots at this point in terms of protection, in terms of the evidence. And then finally, I want to talk about the vaccine, which of course we have very good data on, and want to talk about what a vaccine does. And so I'm fully aware of the time limits that we have, so I'm going to move fairly quickly. We are over 1.8 million people on this planet that have died of COVID-19, and 87 million people which have come down with the disease. Very early on, we had data out of China that was published in The Lancet that there really are three phases, if you will, two phases to the course of COVID-19. You see, when you pick up the virus, there's about a 5-day incubation period, and then symptoms will start after 5 days. For people who progress to need oxygen and even hospitalization, there's about a 7-day period of time where they have symptoms. And then soon after that, if they are admitted to the hospital, it goes downhill quickly from there, where they need respirations, ventilators, ICU care. Again, the course of the disease, there is the phase 1. That is where we have infection, and we try to prevent that with very good implementation of things that we know that work. So staying away from each other as much as possible. And when we can't do that, wearing masks. I'll just mention here that there are really two modes of transmission of this virus. There is large droplet, which masks are very good at preventing. But unfortunately, there's also another mode of transmission, and that is aerosolization. And that you can imagine in someone who smokes. Imagine you're in a room with somebody who smokes. Now, if they're on the other side of the room, you're probably not going to smell it if they start to smoke right away. But after a while, that room is going to fill up with the smoke and you're going to smell it. That's aerosolization. Doesn't matter if they're wearing a mask. It's not spreading by droplets, and masks are very good at preventing droplets, but masks are not very good at preventing aerosolization. What's very good at preventing aerosolization is ventilation. So making sure that the air spaces that you are in are well ventilated. You know, early on in the pandemic, New York had a very, very bad case, a very bad spike surge early on in the spring. And a lot of that was thought to be related to public transportation, the subway system. You may notice today that not a lot of spread occurs on airplanes. And you may be interested to note that the air that gets recycled is 50% air that comes in from the outside and 50% air that is recycled through a HEPA filter, which is designed to take out coronavirus particles. And that, is, I think, is the key. Is not the masks. You're inside of a plane. We do wear masks to prevent droplets, but ventilation is the key. And the CDC has recently updated their site to include that kind of data. So that's phase 1. Phase 2 is something that we see here with people who are symptomatic. Now, if you'll notice here that only about 20% of the symptomatic people, when they become symptomatic, need to go to the hospital, and they go to a phase 3. Which is hospitalization, ventilator, and ICU, and then finally death. But you'll notice that about 80% of these people don't need to go to the hospital. Their immune system actually takes care of it on their own. And the reason why 80% of the people get better is because of the immune system. The cells of the immune system are very important at preventing disease. 80% of people who are symptomatic don't go on to need hospitalization. You can see here there's two types of your immune system. There's the type of the immune system which is called the innate immune system, And then there's the adaptive immune system. Let me briefly elaborate. The innate immune system is that part of the immune system when you are young is very strong, and it creates fevers, and it can recognize things generally as foreign or not foreign, but it's not attuned like T cells and B cells that we would see with antibodies, for instance, in the adaptive immune system. So for instance, children have a very strong innate immune system. They're born with it. They can generate fevers very, very well. And we see in this disease that the children don't usually come down with symptoms usually that require them to go to the hospital. The innate immune system here on the left and the adaptive immune system here on the right. And the innate immune system, as I was saying, is very strong early on, but becomes weaker as you get older. And I think that is part of the problem that we are seeing with coronavirus. And I'll elaborate that a little bit more. One of the things that I want you to understand that's very important is that the innate immune system is involved with the production of interferon, IFN. And that is something that is very important in fighting viruses. The adaptive immune system, which is what you see there on the right, is important in antibody responses, T cells. These are things that are learned after many days after the infection. And unfortunately, it's also the reason why we get the cytokine storm in COVID-19 and pneumonia and hypoxemia that requires admission to the hospital. So very early on here, we saw a couple of papers that were published in Science, which is a very prestigious journal, and it showed that the interferon response was inversely proportional to the severity of the disease. In other words, a strong interferon response here in the blue led to usually mild disease, whereas a smaller interferon response led to more critical disease. Again, you can see here interferon activity when it was elevated led to mild disease. Interferon activity late in the course led to critical disease. So a low interferon response was not good. What you wanted, it was a good interferon response early on in the course of the disease. And we're now finding out that coronavirus, SARS-CoV-2, suppresses the body's innate immune system's ability to mount an interferon response early on in the course. And that's why we see people with a cold-like symptoms and syndrome for many days before they suddenly start to decompensate. And that is when the adaptive immune system kicks in. And because so many cells at that point are infected with the virus, the response is widespread and causes much disease. And so it's important to get this caught early on. So let me quote to you from a PhD in immunology here on June 1st of last year. Studies of SARS and MERS suggest that the interferon response is delayed compared with coronaviruses that cause mild disease. With milder cases of these two coronaviruses, it can cause severe disease. The patients with severe SARS or MERS had higher viral loads and delayed interferon responses. Thus, it could be that the patients most susceptible to severe disease are those that cannot mount an early antiviral immune response. And they went through and looked at those 50 patients. Again, they did another study where they had patients that had either antibodies against their interferon or they had mutations in their own DNA that prevented them from mounting an immune response or an interferon response. All of those patients were grouped in the severe category. None of those type of patients had mild or moderate disease. So there's a lot of evidence that's mounting. So you couple that together with this, what we see increases in interferon response. We know physiologically that fever can induce an interferon response. And here's a paper that was published actually some time ago, looking at the temperature of monocytes and lymphocytes that were taken out of the human body and stimulated as if there were an infection. And we can see that when they were taken out of the human body at 39 degrees Celsius, there was a 10-fold increase in interferon response. So this started to make me look a little bit deeper and understand a little bit more clearly what were the issues going on. It seemed to me that coronavirus was almost designed perfectly in a situation for what we know as hydrotherapy. And of course, we all know that this is what we used to practice many years ago, before we had randomized placebo-controlled trials and antibiotics and things of that nature. And for some of us who may not know this, hydrotherapy was introduced to Ellen G. White back in 1863 from a Dr. James C. Jackson of Dansville, New York, who practiced it. At the time, there was an epidemic of diphtheria. And you can see here what Dr. Jackson himself said. He says, whereas a great number of persons 4 years ago died of the disease in this town and whose deaths caused a real panic among the people, the disease diphtheria has become no more to be feared than any other morbid condition of the body common to our people. That was Dr. James C. Jackson of Dansville, New York. Ellen White obviously talks a lot about hydrotherapy. She talked about the necessity of health reform. Of course, she funded the medical education of one Dr. Kellogg, who had a lot of influence in terms of hydrotherapy. He wrote a 1,000-page book on rational hydrotherapy. And this was not in a vacuum. One of the interesting things that I can tell you about is there was a Austrian psychiatrist by the name of Dr. Wagner Joreg, who in the 1920s noticed in his psychiatric ward in Austria that people with neurosyphilis seemed to get better when they had a fever. So because of the recent work that had been done, he decided to infect them with malaria on purpose. And wouldn't you know that the fevers of the malaria actually cured the patients of neurosyphilis. And then he cured the patient with malaria, with the known treatment of malaria at the time. For this work, he received the Nobel Prize in Medicine in 1927. Ironically, the very next year, in 1928, the world discovered penicillin, and we never looked back. And I'm wondering whether or not there are some lessons to be learned there. Well, here's one of the lessons that was learned. In 1918, Dr. Wells Rubel, who was the medical director of the New England Sanitarium, and later became the first president of the College of Medical Evangelists at Loma Linda, California, wrote this in Life and Health in May 1st of 1919. He said, the present epidemic of influenza has furnished excellent opportunity to test out the efficacy and rational treatment in dealing with respiratory disorders, especially in conditions accompanying and following attacks of influenza. And what he did was he compared in 10 institutions in the Northeast, he pulled the data in the sanitariums and compared it to what was going on in the Army hospitals. In the Army hospitals, they had a completely different viewpoint of how it should be treated. They felt that people were dying of the flu because of their symptoms. So the fever was killing the patients, they felt. And in 1899, aspirin had just been invented, and they were using it like it was water. They were treating the symptoms with lots of aspirin, which of course, you know, takes away fever. And there in the Army hospital, 16% of the patients with influenza came down with pneumonia. And at that time, pneumonia was like a death sentence. 40 to 50% of those patients died. And so overall, about 6.4% of the patients in the Army hospitals died from influenza. Whereas in the sanitariums, they had a completely different approach. They had the patients in the sun. They had exposed them to fresh air. They gave them immediately hydrotherapy, bed rest, these sorts of things. And only 2% of those patients went on to develop pneumonia. Of course, once they developed pneumonia, there was still a very high mortality. But overall, only 1.1% infection fatality ratio. Here's the article about Julius Wagner Joreg, who won the Nobel Prize. So I'm wondering if potentially there is something that we can do that might help, at least in the early phase of this virus. And for those of you who are more interested in understanding this, I encourage you to go to hydrotheraphyathome.com, which has been developed just for this type of thing. And also the Adventist Medical Evangelism Network.org or amensda.org //COVID also has some resources as well. All right, so that's talking about that. I'd like to move along to vitamin D real quickly. And what we're finding out is that a lot of patients who are being admitted to the hospital are vitamin D deficient, particularly those with progressive COVID. Now, vitamin D is one of those things that is, we think of it as a vitamin, and so it's one of these things that you can buy over the counter. It's not really that important. If you look at the structure of vitamin D, you'll find out very quickly that it's a very similar structure to very important hormones that are made in your body, like cortisol, like aldosterone, testosterone, estrogen, progesterone. Vitamin D looks very similar, and that's because it works very similarly. It's a steroid hormone that goes actually into the nucleus of cells and causes transcription of very important proteins. The problem is that vitamin D, for the most part, is made from the sun, specifically ultraviolet B radiation, penetrating deep into your skin and converting a cholesterol derivative into that vitamin D. And so the problem is that the less sunlight exposure you get, or the darker your skin is, you're going to get less and less vitamin D. This has become a big problem, especially in people of color who have moved from the equator to northern latitudes. And as you can see here, vitamin D is a fairly large problem in people of colored skin. You can see here that if you look at the nanograms per milliliter, those that have greater than 30, you can see the breakdown of that here. Most people in this category are those of fair skin, whereas at the lower concentrations, they are made up primarily of people with dark skin. And so this is a large problem. Also, when you consider the fact that these are the very same people that are being affected most in COVID-19. There was a large study that was done in the United States. Over 190,000 people were observed. And there was this correlation between people's levels of vitamin D. So here we have 60, 50, 40, 30, 20 nanograms per milliliter. And here on the y-axis, we see the positivity rate of SARS-CoV-2. And this was all around. You could see that almost a perfect explanation here as to why these levels were elevated. Now, of course, causation doesn't, or association doesn't necessarily mean causation. But what was interesting is that no matter how you cut this or sliced it, the relationship was still there. Whether you looked at geography, the relationship was still there. Whether you looked at race, the relationship was still there. Whether you looked at age, again, the relationship exists, or even gender, the relationship exists there. And so this has been repeated multiple times in multiple countries in multiple ways, and this relationship keeps showing up. And so now they are looking at randomized controlled trials, looking at vitamin D in the prevention of the progression or even getting COVID-19. There have been a few that have come out, 3 that I'm aware of. In one that was a negative study, they gave 1 huge dose and then failed to supplement them after that. We even know with antibiotics, we don't do that. We know that we have to give it continuously. In the other 2 studies, they were both positive. In one study that was out of Spain, using a derivative of vitamin D, there was a dramatic reduction in need for ICU care. And also there was one that was done in India called the SHADE study, ironically. And it showed there that it reduced viral load significantly, and it also reduced inflammatory markers. I'm encouraged to know, however, that in Boston, I was made aware that they're looking at about 3,000 patients to do a randomized controlled trial in the United States with using vitamin D, and hopefully we should have more information coming up in April or May of this year. Again, more data. But now let's move on to the topic at hand, which is the vaccination. And I guess I could say that if this were the religion of molecular biology, we're now about to do Sabbath school. So what we're about to do is talk a little bit about how the body works so you can understand how the virus works and then understand how the vaccine works, because that's really key. If you just try to learn about the vaccine in that kind of a vacuum, it doesn't make sense. So what I have here is a cell, and the cell has a nucleus, and in the nucleus is the DNA. This is the code that runs every single aspect, pretty much, of every cell in your body. Every cell has the same code. Certain aspects of that code are expressed depending on the cell type. I want you to think about DNA, though, like your Social Security card in your filing cabinet at home. You don't pull it out, you don't take it out, you don't use it when you're filling out. I mean, you could use your Social Security number, the code, the information for multiple things, filing your taxes, buying a car, taking out a loan, but you never really take out that Social Security card. You never laminate it. You don't do anything of the sort. You leave it in the filing cabinet in case you need it. And that's exactly what happens with the DNA. A copy is made called the messenger RNA of that particular code that you want to copy. That messenger RNA then goes into to the cytosol, or the cytoplasm outside the nucleus, where something called ribosomes convert this information on the mRNA into actually active things called proteins. Proteins can be enzymes. Your hair is made up of protein. Your skin is made up of protein. The stuff that you want your cells to make and do is all really protein. And so this is how the cell works. Okay, now let's enter in a virus. So a virus comes in this case, it's coronavirus, and it merges with your cell. What it does is it dumps in a messenger RNA of its own. So it has its own code. And in this case, it's a very, very long messenger RNA code. The ribosomes can't tell the difference between your cell's messenger RNA and the virus's messenger RNA. So they just go ahead and convert that code into proteins. And what kind of proteins are they? Viral proteins. Now, there's something I should mention about this messenger RNA. You know, if you were going to take a loan out, and let's say you'd forgotten your social security number, you would go to your filing cabinet, pull out your social security card, and write down the number on a sticky, right? On a 3M sticky note. And then you'd paste that somewhere. Well, you know, a month from now, what would happen to that pasty sticker? It'd be gone. It'd be thrown away. Hopefully shredded, right? Because it's got your social security number on there. That's exactly what happens in the cell. This messenger RNA, whether it comes from the DNA, from the nucleus, I should say, or whether it comes from the virus, doesn't stick around. It goes away after a day or two, sometimes even earlier than that. That's how the cell can regulate what it's doing from day to day. The message goes out, the message gets destroyed, okay? Just like on Mission Impossible, this message will self-destruct in 5 seconds, okay? Sometimes it's usually longer than that. So that's important to understand, because when we're talking about vaccines that are messenger RNA, some people think that these things hang around for your life. They don't. They only last for a very short period of time. So the messenger RNA goes in, the ribosomes convert it, make viral proteins. And here's the key. The cell makes more virus. So one virus goes in, thousands of viruses come out of that cell and makes more viruses. And those viruses go to other cells. And so the way to really prevent this infection from happening, and by the way, here we actually, people say, have you actually seen the virus? Do you know that it's a virus? Yes, we know it's a virus because we have scanning electron microscopy and electron microscopy of these very viral particles coming out of cells. Here's the cell, and here are the viral particles that are budding off, going to infect other cells. And here's what these things look like. You can see the spike proteins. It looks like a crown. That's why it's called the coronavirus. Corona means crown. So how would we stop this virus from coming into the cell? Well, there's these little spike proteins on the surface of the virus, which interact with proteins on the cell surface. If we could coat those with protein binding, this virus would never be able to bind the cell surface, and we would get rid of the infection very quickly. The problem is that somewhere in the body is the right cell to make this antibody, and that cell doesn't know that it needs to be activated and cloned and duplicated until the infection has already happened. And so you only derive antibodies after the infection has happened. So what we're trying to do with a vaccine is to give you a head start and have those antibodies there before the infection actually occurs. In addition, you get B cells and T cells. T cells attack cells, B cells attack the virus. Your immune system is fearfully and wonderfully made. So the problem here, though, is that in an infection, when you get the exposure, your innate immune system kicks in. Unfortunately, it's suppressed in coronavirus. The viral load starts to increase because you're infecting more and more cells, and it grows exponentially until your immune system kicks in. And then you have adaptive immune response, which then kicks in. But sometimes it can be maladaptive and cause you to go into pneumonia. So what does the vaccine do? Here's what the vaccine does. The manufacturers at Pfizer and Moderna both use a messenger RNA, which give the code for not the virus, but only a portion of the virus. In fact, it's the most important part of the virus for us to try to prevent the infection, and that's the spike protein. So the information for the ribosomes to make the spike protein are encapsulated in a little butter particle, if you will, a lipid particle that when injected into your body will go into muscle cells, will go into your immune cells. It will fuse with it. The messenger RNA, which is a sticky note, okay? It's a sticky note. It's not going to last very long. And the messenger RNA is then translated by the ribosomes into these spike proteins. The spike proteins cannot reproduce. These are not whole viruses. And so they only stay in the cells that the messenger RNA goes into, which is very limited. It's in your arm where you get the shot, and it's in the immune cells that take it away from there. Causes the immune response. You now get B cells, you now have T cells, you are now primed, ready to go, so that if coronavirus actually comes into your system, you are now ready to knock it out. So here's what the vial looks like. I mean, this is what it is. Notice there's no microchips in there. You can put the needle in. Each one of these serves about 5 or 6 people. So, you know, if you had 5 or 6 microchips in there, how is the guy going to draw up 5 or 6 micro? I mean, I'm being facetious here, but this is the vial. This has got little butter droplets with messenger RNA in there. You drop, it goes into the body and it does the thing. And that's what it looks like. So let's take a look at the 3 that are probably going to be available. The first 2, Pfizer, BioNTech, and Moderna, are both messenger RNA vaccines. Okay. So they go into and they do exactly what I was talking about. Now, there is one called the AstraZeneca Oxford vaccine, and this one uses a little different thing. Let me go back to explain that. Instead of using a butter particle, I like to call it, or a lipid particle, they actually use something different. They used an adenovirus, a chimpanzee adenovirus, gutted of all of the genetic material inside so that it would infect the cell. The reason why they used the chimpanzee adenovirus particle is because humans haven't seen adenovirus chimpanzee viruses, adenovirus. And so we didn't want to have an immune response against the very vector that's going to take the information to the cell. So inside that cell now is not messenger RNA, but in fact, it is DNA. Okay, so that one does need to go into the nucleus, but the manufacturers of the AstraZeneca Oxford vaccine say that that double-stranded DNA does in no way incorporate or go into the DNA molecule that's already there. It gets broken down. The DNA then gets transcribed into messenger RNA, and then the rest is exactly the same as what we've just discussed. So I've probably said enough. I will close it there, and I'll ask and see if there's any questions.
Thank you so much, Dr. Seheult. This is just such a wealth of information, and we know that you really just shared the tip of the breadth that is out there. And it really reminds me that we are truly fearfully and wonderfully made. We have time for just a couple of quick questions before we go to Dr. Williams. So we had some questions that were submitted to us previously. I'm going to just ask a couple of those very quickly. For one, you mentioned how 2 of the vaccines use the spike protein. Now, what about the new strains of coronavirus that are emerging and that are spreading fairly rapidly? Are these vaccines going to be effective against those? And as a second part, how concerned should we be about these new strains?
Okay, very good. So we just recorded an interview with Dr. Shane Crotty, who is a PhD. He's one of the top immunologists in the world working out of San Diego. And we posted on MedCram, and we actually asked him that very question. And so I will summarize that video for you here in a few. There's 2 variants right now that are in question, and that is the UK variant and the South African variant. From all of what I can tell, the UK variant is probably not going to be a problem. It's going to be covered by the vaccines that we have already and currently made. We on the South African variant, however, we don't have yet enough information to tell. Why are we concerned about that? There seems to be a lot of mutations in the spike protein in that variant. And so there is some concern that there may be what they call escape mutation, where it escapes the immunity that we're currently getting from the current vaccines. Fortunately, we should know in the next couple of weeks whether or not that is going to be the case. We do have 95% efficacy with the current vaccine against the wild type strain or wild type variant, the one that we have now. The South African, we don't know yet.
Okay, thank you. We do have one attendee asking if you can put back up the last slide that compared the 3 different vaccines. And while that's on there, I'm going to ask you the next question. Comparing the adenovirus and the mRNA vaccines, do you have any indication as to which of these would maybe have more adverse effect on individuals who have an autoimmune disorder or who may have other food or drug allergies? Do we have any information about that?
I don't have any information about autoimmune. In terms of allergies, however, there has been some increased risk of allergies in the Pfizer and Moderna. However, right now that is at approximately 1 in 100,000. To put that into perspective, if I were to be giving out penicillin injections, that would be 1 in 8,000. So that's a much higher risk of an allergic reaction with penicillin than we currently have with these vaccines. So they are very safe in terms of anaphylaxis or allergies. Now, to get back to your question, your viewers would be very interested to understand in terms of autoimmune. You have to realize that here with these vaccines, you are getting only a small portion of the spike protein that you're causing an immune reaction against. If you were to be infected with the entire virus, the immune system is going to pull apart that virus and expose to the immune system multiple epitopes, multiple antigens, multiple particles of that virus. And the autoimmune response is going to be much more varied, diverse, and large. And therefore, theoretically, the chances of an autoimmune condition arising is actually, in my opinion, and many others, higher with a actual viral infection than it would be to the vaccine. We have multiple evidence of people who have been infected post-virally and have come down with autoimmune conditions. Guillain-Barré, for instance, after Campylobacter, that's a bacterial infection. And so the list goes on and on and on. So to think that the risk of autoimmune diseases only comes with vaccination and not getting the virus itself is a misnomer.
Thank you so much, Dr. Seheult. We do have more questions coming in. We have others that we want to ask you too, but thankfully you'll be able to hang on with us for until the end of the program. We're going to go now to Dr. David Williams, our next presenter.
Thank you so much, Dr. Brower. It's truly a pleasure and privilege to be with you today. I am so thankful for the presentation we've just heard that gives a lot of the biology of the virus that is really it's important background for us to understand. I will talk more about some of the social context and some of the questions that are emerging about the virus, and also put the virus into a larger context for all of us as we think about it. I'm going to share my screen here to get started, and give me a second. And I want to begin by talking about the virus. I was looking just today at a public opinion poll that found that 35% of all Americans, adults, believe that the seriousness of the virus is exaggerated in the news. And that goes as much as high as 50% of Americans who live in rural areas. So a lot of people don't know how serious the virus really is. And I want to tell you that the US is the epicenter of the virus. We are 4% of the world's population, but 25% of all COVID-19 cases in the world are in the United States. 20% of all COVID-19 deaths in the world are in the United States. And we are the country with the largest number of deaths compared to any other country. Just to give you a sense of how quickly this has emerged, this is the number of deaths each month in the United States from the virus. And you could see this peak that occurred, and we had 0 January of last year, 1 in February, and then this peak that occurred in April. And then things kind of were at a much lower pace, but then they have really picked up in November and December. December was the deadliest month of last year. For those of us who study public health and the causes of death in the United States, we know that the #1 cause of death in the United States, it has been for decades, heart disease, and #2 is cancer. And what I'm showing you here is from heart disease, the daily mortality rate in the US is approximately 1,700 people die each day in America from heart disease, and about 1,600 die each day from cancer. But from the coronavirus, from COVID-19, we have approximately 2,430 deaths per day. That was from November 1 through the middle of December. What am I saying? More people are dying in America every day from coronavirus currently than are dying from heart disease or dying from cancer. So it is, in fact, a huge problem. And I just want to even put it into context that maybe you can grasp the seriousness of the pandemic we're dealing with. The daily deaths from COVID-19 is equivalent to having all the deaths from September 11th, which was 2,988, occurring every 36 hours. So think of the people who died on September 11th. What we are seeing with COVID now is that number of people dying every day and a half, that many people. Another way to think of it, imagine 15 jets, Airbus 320 jets, each with 150 passengers on board, crashing every day and everybody on board dying. That's what we are saying. 15 jets crashing a day. That kind of gives you a context of how many people are dying in the United States from COVID-19. So what does the church have to say about COVID-19? This is a statement not specific to COVID-19, but on vaccines, issued back in 2015 by the General Conference of Seventh-day Adventists. The Seventh-day Adventist Church, the statement says, places a strong emphasis on health and well-being. The Adventist emphasis on health is based on three things: biblical revelation, the inspired writings of Ellen White, and peer-reviewed scientific literature. So we look at the Bible, we look at the spirit of prophecy, and we look at science. Therefore, the church encourages responsible immunization and vaccination, and the Adventist Church has no faith-based reason not to encourage our adherents to participate responsibly in protective and preventive immunization programs. We value the health and safety of the population, including the maintenance of herd immunity, but the church, we are not the conscience of the individual parishioner and recognize individual choices. These are exercised by individuals, but the decision not to be immunized is not and should not be viewed as a doctrine or dogma, a teaching of the Adventist Church. So this is a pretty balanced statement. But one of the things it says that I think is really important when it talked about where our sources of information come from, it was the Bible, the spirit of prophecy, and science. And I think as Adventists, we should listen to what science has to say. I'll share with you two quotations from the spirit of prophecy. Ellen White says, rightly understood, and that's a big caveat, rightly understood, science and the written word agree, and each sheds light on the other. So understanding the science and the findings from science helps us to better. Science sheds light on scripture and vice versa. Together, they lead us to God by teaching us something of the wise and beneficent laws through which he works. Another statement, rightly understood, they, science and the Bible, are in perfect harmony. All truth, whether in nature or in revelation, is consistent with itself in all its manifestations. And that's why I so appreciate the earlier presentation you just got that gives us the science. Rightly understood, science and the Bible are in perfect harmony. So we shouldn't be afraid of science, and we shouldn't automatically dismiss science. We need to make sure we are properly understanding it. Rightly understood features prominently in both of those statements from the spirit of prophecy. I like to think of God as the greatest scientist in the universe. And we do not have to choose between the Bible and science. I think that's a false dichotomy. God is the greatest scientist of all time. Each sheds light on the other, the spirit of prophecy tells us. Rightly understood, they both lead us to God. God's word is primary, takes precedent, that's where we begin, but we try to understand them together. I want to say something else that's important for some of the topics I'm going to cover and some of the challenges we face in the church, that when it comes to COVID-19, but when it comes to health, when it comes to the health message, when it comes to information we provide to our communities, it is important to our witness that we be accurate in what we say. We don't take anything just because it's on the internet. We really want to be accurate. And the spirit of prophecy says, if they, the public, see that we are intelligent with regard to health, they will be more ready to believe that we are sound in Bible doctrines. And think of the flip side of that. When people see us saying things that are patently not true scientifically, they will dismiss everything. If we don't have our science right, they don't think we'll have the doctrines right either. So that as part of our comprehensive witness, it's important that we be careful, we check the facts, and we only share that which is accurate. It's part of being faithful and representing God and his health message, that we are accurate in what we provide to our communities and to our members. I want to talk about several of the concerns that individuals have. Here is a national study done by the Kaiser Family Foundation. It was done between August and September 2020. And this is the percent of adults saying that they would not get the vaccine for COVID-19, even if it were free and was determined to be safe by scientists. And you can see 33% of whites, 37% of Hispanics, 49% of African Americans said they wouldn't get it. So it's a real problem, and there's a lot of concern in the public health community about populations of color and what we can do to address this vaccine hesitancy problem. Now, what makes that finding particularly striking is these are the deaths, COVID-19 deaths through December 8th. And you can see this is the risk, the greater likelihood. So Native Americans are 3.3 times more likely to have died from COVID-19 compared to the white population. Latinos and African Americans are 2.7 times more likely. Pacific Islanders 2.3 times more likely. So these populations of color, we have concern because of the elevated risk of death. But we also have concern because we see really greater reluctance of taking the vaccine. And let me also share another statistic. These are the comparative rates. So the rate is so much higher in this group than another. Many people get confused, I think, with the rates and think that the numbers of deaths are greatest for these populations of color, which is not the case. So here are the number of deaths so far for different population groups. 2,800 for Native Americans, 51,000, almost 52,000 of Latinos, almost 50,000 African Americans, 435 Pacific Islanders, 9,400 Asians, and 151,000 whites. In fact, more whites have died from COVID-19 than all the other groups combined. And I think that's not the impression many people have, because they hear of the higher death rates in the populations of color, and some whites think, oh, that means we are not at risk. No, you are at lower risk of death, true, but because there are a lot more whites in our total population, the largest number, 151,000 deaths of the white population. So all of us need to be concerned, and all of us need to share the message with everyone. Let me talk about some of the myths. One myth that's out there is that the vaccine was developed too fast for it to be safe. The fact is that the companies, pharmaceutical companies that have been making the vaccines, and there are 2 vaccines approved in the United States, and we expect the 3rd one to be underway pretty soon. The companies did not bypass safety protocols or do inadequate testing. That's really important to understand. The FDA does have emergency authority, which is how the vaccines have been approved, to issue temporary approvals for medical products to get them out quickly, and in the context of a public health crisis. And my data earlier shows we are in a major public health crisis, maybe the worst one since 1918. An emergency response is appropriate in an emergency situation. Since February, the FDA has used its power to authorize not only the vaccines, but many of the treatments, including the treatments that President Trump got were on the emergency use authorization, for example. So is it really too fast to be safe? Now, it's true that what has happened here is a little different than what normally happens. The FDA has previously authorized a vaccine that way only once, and that was in 2005 against anthrax. To receive emergency use authorization, though, the pharmaceutical company must follow at least half of the study participants for at least 2 months after being vaccinated. So yes, the study has been done and people have been followed for 2 months. On the normal circumstances, we would continue. Well, let me put it this way. Those people who have been studied, the studies are ongoing. The studies have not stopped. So more data about the vaccine will become available. But after 2 months, we can look at the efficacy. It's safe and it's effective. So, and these are pretty large studies. The Pfizer biotech study is 43,000 people. Half of them getting the vaccine, half of them getting a placebo. Think of it as salt water. It's not exactly, but something that is totally ineffective. And you look to see what are the differences in these two groups. The safety of the vaccine, the efficacy of the vaccine will continue to be followed in these populations. So the studies have not come to an end, but in a context when so many people are dying globally, and we have good evidence with 2 months of follow-up, and I would say what we know from vaccines, most of the negative side effects occur early. Now, I'm not saying every single one, that's why we follow for a longer period of time, but most, if there are really big problems, we see them early. So with 2 months of good quality follow-up, I think it's, in the context of the number of deaths that we are facing every day, it is a prudent thing to think of the vaccine. It is true, vaccines have historically taken many years to develop, but part of what has happened is the science has advanced. You had learned about messenger RNA. One of the benefits of using messenger RNA, it cuts out some of the normal time-consuming steps. So it's part of the greater speed with which the vaccine has developed really reflects the advances in science. I would be not being honest with you if I didn't say that the short-term safety data, the fact that there's only 2 months of follow-up, is a limitation. This is shorter than in many traditional trials. That's one of the reasons why emergency use is being used, because ideally we would want a longer follow-up. And there are questions about, okay, what is the potential effects, medium term, long term. I have made the point that it's true that in general, if there are really major problems, we typically see most of them early, but ideally you want longer term follow-up. But importantly, the intensive safety monitoring will continue as the trials continue. So in the context of everything, and you look at what are the costs and what are the benefits, it is in fact a reasonable thing to do, and there have been no shortcuts to the science. That's important for everyone to know. I like to tell populations of color that here is the role of a Black scientist, Dr. Corbett, who is a leader of the Vaccine Center Research in Dr. Fauci's NIH agency. And she has been a key scientist behind the development of the Moderna vaccine. So just letting you know that, yes, minorities have actually played a role in the contribution of the science that has been developed. Another myth I want to talk about quickly is COVID-19 vaccines have severe side effects. Actually, the good news of the vaccines, and I really think is good news, and I'm telling you, I will get a vaccine, I will take it as soon as I can get it. The good news is there are short-term, mild or moderate vaccine reactions that resolve without complication or injury. The early phase studies clearly show these are safe. About 15% of the people had brief symptoms at the injection site. That's a little soreness at the place where you receive the injection. Another, about 50% had like a headache or chills or fatigue, muscle pain or fever lasting for a day or two. Importantly, those are good things. Those side effects indicate that your immune system is responding to the vaccine, and that's common with vaccine. And I've spelt out here the side effects for the Pfizer vaccine is pain at the injection site, chills and fever and fatigue. For the Moderna vaccines, the same pain at the injection site, but more muscle aches and headaches. But these resolve quickly, typically a day or two in about half of the people, and only about half of the people get them, which means another half of people don't have side effects. So that really, in the big picture, the side effects are in fact mild for most people. There have been a couple of reactions reported of people in the UK, particularly who were very allergic, had very strong responses to allergies and treatment for other vaccines, and they need to be careful. But in general, it is not a big problem. Another myth. Some have said, there are websites that say that the vaccine side effects, because the death rate of the vaccine is low, the vaccine side effects kills more people than the virus. That's a social media claim. And they're saying, well, the overall death rate is low. There's no need to be vaccinated for the virus. Importantly, a 1% mortality rate is 10 times more deadly than the seasonal flu. And the seasonal flu does cause a number of deaths a year. The mortality rate varies by age, sex, race, and health conditions. So that's higher for some people than for others. Yes, some people will develop symptoms as their immune system responds, but the symptoms are not serious. The symptoms are not life-threatening. So it is absolutely incorrect to claim that a vaccine kills more people than the virus. And I would emphasize the benefits of vaccines outweigh the risk in healthy people. You cannot get COVID-19, this is also important, infection from COVID-19 vaccines. There are websites that claim that. They are inactivated vaccines and not live vaccines. Getting vaccinated is also not just about surviving COVID-19, it's about preventing the virus from spreading and preventing deadly infections. No vaccine is 100% effective, but we have really impressive numbers in the mid-90s, 94%, 95%. Those are really, really great numbers. And they are far better than not getting a vaccine. Another myth, I don't need vaccine. I already have had COVID-19. Well, right now, we don't know the answer to that question. So we would recommend caution. We don't know whether people who already were infected, that means they got natural, if they got natural immunity, we do not know that. And so that right now, some evidence suggests natural immunity from COVID-19 may not last very long, but we don't definitively know that. Some experts recommend getting the COVID-19 vaccine, even if you've had COVID-19 previously, but they suggest you should delay vaccination until 90 days after diagnosis. So wait 3 months after you were diagnosed with COVID-19 before you get the vaccine. People should not get vaccinated if they're in quarantine after exposure or if they have COVID-19 symptoms. So that's the same point. Should I still get, I'm gonna move on quickly because I wanna cover a couple other topics. A big question that many people have is, when will I be able to get vaccinated? As you know, there are priorities that have been established. It's linked to your job. Are you working on the front line of the pandemic? Your age, the risk of severity and death increases with age, so older people have higher priority. And certainly if you have underlying conditions, that is important. Healthy young adults without medical conditions or high-risk jobs have the lowest priority. Importantly, I think children were not included in the early vaccines. So right now we shouldn't be, we don't have data on kids yet. Pfizer is the first company to expand its trial to people 12 and older. So even coming a little younger, but then younger than 12, we literally don't know everything. I would say to most people, it will probably be late spring or early summer before everyone in the United States has general access to vaccines. So it will be a while, and the rollout is moving forward, but it's actually even taken a little longer than we initially anticipated. one of the important characteristics of the vaccines that are available right now is that you need 2 doses, both the Moderna and Pfizer vaccine. Pfizer you need a booster shot 3 weeks after the first one. Moderna is 4 weeks after. The third one approved in England and in Europe is 4 weeks later as well. You know, and so that's really important. There is some discussion of whether for some people, there was the AstraZeneca Oxford vaccine. It was more effective when the first dose was half the typical dose, and the second one given 4 weeks later. And there are even discussions in the US right now that are taking place of whether the first dose could be half the dose. Whether that will be approved or not, we don't know, but that's the context. There is science behind it. So don't think they're just trying to save on the doses. There is some science behind it as well. How much will the vaccines cost? Good news. The vaccines will be free. The United States government has pre-purchased hundreds of millions of vaccines doses with taxpayer dollars, and they have committed that they will make it free to all Americans. So that is in fact good news. Myth, I won't need to wear a mask if I get the vaccine. And no, I would say no. To show that you care for others, you should still wear a mask. First of all, it may take time for everyone who wants a vaccine to get it. And while the vaccine may prevent you from getting sick, it is unknown at this time if you can still carry and transmit the virus to others, even though you are protected. We do not know the answer to that question. So until we know more of how well the vaccine works, continuing the precautions such as mask wearing and physical distancing will be important even if you have been vaccinated. So will you still need to social distance? Yes, the answer to that is yes. I want to end by talking about a couple myths and then talk just a bit about prevention. A myth that is out there is that COVID-19 vaccines were developed to control the general population, either through microchip tracking or nanotransducers in our brains. I have heard of at least one Adventist evangelist who's talking about this. The vaccine may be some microchip that gives you the mark of the beast and so forth. Folks, the fact is there is no vaccine microchip, and the vaccine will not track people or gather personal information into a database. This myth started after comments made by Bill Gates about a digital certificate for vaccine records. It was talking about, and I'll come back to that in a minute. There might be systems developed to keep track of who gets a record. And then the airline can just punch that in to see when you're trying to buy a ticket, have you gotten your vaccine or not? However, the technology he's talking about is not a microchip. It's not something that's being put into the vaccine, and it's not something that we need to worry about. Another one, I think this was hinted at in the previous presentation, the COVID-19 vaccine will alter my DNA. No, the first COVID-19 vaccines to reach the market are messenger RNA vaccines. They work, mRNA vaccines work by instructing the cells, as we were told. Injecting mRNA into your body will not interact or do anything to the DNA of your cells. So you don't have to worry about that. That is not true. Another question that some people have is, will I have a choice of which vaccine I can take? There are multiple vaccines out there. I think for most Americans, we will not have a choice in the next few months. Part of the reason is we don't have, as the supply of vaccines is less than the demand. The Moderna vaccine is more flexible to be used in small pharmacies in rural areas, but small hospitals. The Pfizer vaccine needs much more refrigeration and comes in larger capacity. So I think at some point, maybe a year from now, you could pick and choose which vaccine you can get, but most people will not have a choice in the short term. What will happen if I don't get vaccinated? So importantly, what's the big picture goal? Our goal is to create what scientists call herd immunity. And that is when enough people are immune that its disease no longer spreads, or I should say no longer spreads at a rapid pace. And we don't know a specific number for that, but that's somewhere in the 70 to 80% of the population range, we think, when that happens. So given the goal of protecting not just your health, but your neighbor's health, being part of establishing herd immunity is a good thing. Couple more questions. Can my employer require me to get vaccinated? Early on, many legal authorities said that because the FDA's authorization is emergency authority, that it could not be mandated. A ruling from the EEOC, that's a federal agency, says that employers have a right to impose mandatory COVID-19 vaccination if they want to. So we do not have, can your employer require you? Yes, they can. You can refuse on the current regulations because of religious reasons, not personal reasons, not political beliefs, but religious reasons. Employers must make reasonable accommodations to meet your religious objection, but not if it causes undue hardship. So many employers may require it and may feel that there isn't reasonable accommodation they can make. Reasonable accommodation is, for example, they could allow you to work from home, for example, and so on. Can you be mandated to get a vaccine by others? Yes, not by law, but I saw an interview with the CEO of Qantas Airlines, and he said at Qantas, they haven't implemented this yet, but they have decided that if you're going to take an international flight on Qantas, you will have to produce evidence that you have been vaccinated. And that is likely to happen with hotels, with sports stadiums, with gyms, with employers in some fields. So yes, it is likely that many of us may have to be vaccinated to function normally in society, especially things of flying and transportation. Those may well be required. We aren't there yet, but that is likely to be the case. Another myth I want to talk about briefly is there are a number of videos. I've received many from wonderful Adventists who've seen them, and that is that cells derived from aborted fetuses are being used in the COVID-19 vaccine being developed by Oxford AstraZeneca. The fact is, aborted babies are not being used for the development of COVID-19 vaccines. It is true that human cells are required in order to grow the COVID-19 virus when developing certain vaccines. And this is done in science routinely. Fastest and most reliable way to study human pathogens is to study it within human cells. It is also true that some cell lines established years ago were derived from cells from electively aborted fetuses. And these lines are widely used in medical research and in the production of some current vaccines like hepatitis A, rubella, chickenpox, and rabies. They have also been used to make approved drugs against diseases, including a list of diseases here: hemophilia, rheumatoid arthritis, cystic fibrosis. So yes. And so the Oxford vaccine, the cells used in creating that vaccine are not the originally harvested cells from that aborted fetus. They are laboratory cultivated distal descendants, that's the best way to think of them, of the cells originally obtained in the 1970s. These cells were derived from human embryonic kidney cells. The line was developed back in 1973. However, the vaccine itself contains no actual fetal cells and no fetal DNA. So I just think we need to be clear on that. It's also important to realize that human cell lines, most vaccines benefit at some stage of the development from human cell lines. There are 6 COVID-19 vaccines being developed that have used human fetal cell lines. And even the Vatican, and I'm not saying we have to follow what the Vatican says, but it reflects clear deliberation by a church that has strong feelings about abortion, declared in 2005, reaffirmed in 2017, that in the absence of alternatives, Catholics could, in good conscience, receive vaccines made with historical human cell lines. Let me end by just talking about the importance of prevention. We can think of prevention from a public health point of view. I just want to encourage you as a professor of public health, please follow the public health guidelines. And these are some things we need to do better. But going back to the other presentation that we had that was so excellent in so many ways by Roger, is that we need to think of strengthening the immune system, and getting adequate vitamin D is one of those things, especially those of us who live in northern latitudes. Even if you get sunlight exposure between late October and February, in places that I would say that are north of a latitude line, that's Atlanta and Los Angeles, if you're north of that in the United States, you do not get vitamin D in the winter months, even if you have sun exposure. So in the winter months, many of us need to get vitamin D supplements, but there are other things, the 8 laws of health, that have principles that help to build our nutrition, and we should keep those things in mind. So let me conclude. The science is abundantly clear. Vaccines save lives. That has been historically true in the last 100 years. I also understand that some people may have legitimate deep-seated fears about the COVID-19 vaccines. That's reasonable. And that's why we are offering the symposium to provide you facts so that you know what the facts are. The COVID-19 vaccines, in addition to ongoing hand washing, distancing, and mask wearing, offer us a new opportunity, not only to protect ourselves, but to be a good neighbor and protect those around us. Part of staying safe and keeping your family involves making sure you have the information you need about the vaccines. And I encourage you to get good information. I just heard, I'm familiar with Amen, but I just heard about the Amen website as a wonderful resource. I didn't put them on the list because I didn't know about that, but I would add them to this list. But think of reputable sources, the CDC, World Health Organization site. My school has a site, the Harvard Chan School, the Harvard Medical School has a coronavirus resource center. Johns Hopkins has a coronavirus resource center. The Conversation is a science, a group that tries to put the science in simple language. So those are other places for more information that you can get. So my plea is to get credible, accurate information, and not everything that is on a website or is online is accurate. Okay, at this point, I will stop so that we can see if continue with the program.
Thank you so much, Dr. Williams. That was a wealth of information, and you absolutely addressed many of the questions that have been coming into the chat, as well as what we received earlier. So we're going to do this very quickly. We're going to switch to the next portion of our program, and then we're going to come back together for the question and answer time with our 2 presenters. So what we're going to do is we're going to split off into breakout groups. Now, every single one of you in attendance will automatically be placed into a breakout group. You might receive a little pop-up box that says join breakout group so-and-so. Just go ahead and click OK to that. You will have a group leader there waiting with one question that your group is going to discuss. And then we're going to come back after about 13 minutes. We're going to give you 13 minutes to talk about, respectfully dialogue about the question. And then we're going to come back and go to our Q&A time. All right, so Philip Riley is going to put you in a group now. So go ahead, Phil, send us to our groups and stick with us. We've got a lot more coming. Everyone is coming back. Thank you all so much for participating in those conversations. Now, unfortunately, we usually like to come back, spend a few more minutes sharing the conversations we've had. We unfortunately don't have time for that today. We do want to get to addressing some of those questions, but I'm going to ask our group leaders, and if you could just send me a quick email with the summary of the conversations that you had. What we can do is post that on our website as well. And Phil, I'm going to ask you if you could put a link in the chat to our website, to our ministry goals page on our website. That's the link that you can use to find the recording that has been of this webinar. You will also find the resources, the links that our presenters have mentioned. All of that information will be there. So Phil will put that in the chat. Well, let's go now to some of the questions that have been come in. I've been noting the ones that you've posted in the chat, but also we have a few that came in prior as well. Now I'm going to open up the first question to both of our presenters. We heard about the vaccine testing process, the development process, and that and really we've had a very short time frame for development, for testing. One of the questions that has been asked is, because we don't have long-term results of the vaccine safety, do you think it is responsible to get the vaccine at this time, given that we don't know what's going to happen 3 months from now, 6 months from now, a year from now? And I'm going to ask Dr. Williams if you would answer that first, and then Dr. Seheult if you would follow up as well.
Benefits far outweigh the potential negatives. We have good follow-up for 2 months. That follow-up is ongoing, so every month we will be getting more information, and at some point, you know, the vaccine manufacturers will go, instead of just emergency use, they will ask the FDA to provide full authorization for the vaccines. So we will have that data, and I was very clear in my presentation that 2 months is a short period of time, but that must be balanced by the fact, if we look at what has happened in the past, most of the major negative side effects that occur early. So it's not a guarantee. We don't know, but I think if we look at the impact of the pandemic and the massive loss of lives, and we look at how effective this is, and with the side effects that we have so far that are really mild to moderate, yes, it is a good thing. And I would tell you, I will take the vaccine as soon as I can get it.
I thought Dr. Williams did a great job answering that question. I'll just add a couple of things. I'll often hear them say, you know what, there's a 99% chance that I'm going to survive this. Why even get the vaccine? Well, first of all, there's a couple of things. Number one, it's not a live or die issue. It's, yeah, the 1% die. It's not like the 99 go on with their lives perfectly normal. There's been a recent study that showed that 50 to 60% of athletes after getting coronavirus had signs on MRI of myocarditis. And so, you know, there's this term long haulers. I've had patients that we're now just starting to see. And so, yes, we have a paucity of long-term data in the vaccine, but we also have a paucity of long-term data in the infection itself. And so you're not choosing between perfectly healthy, normal, don't do anything, and you'll be just fine, versus this vaccine that may have some long-term complications. You're choosing between a vaccine which may have some long-term complications that we don't know about yet. And by the way, those usually pop up very early. So we'll find out very soon, versus you take your chances with the virus itself. To think that the virus is a natural virus and you're going to be just fine. I mean, we see people all the time after getting a virus that have post-viral complications. The second thing I would say is, as it was talked about, we talked about in our breakout session, in Romans 14, Paul says very clearly that no man lives unto himself, and no man dies unto himself. You've heard the expression, no man is an island unto himself. And so to make this decision about whether to get a vaccine and look and see if it's right for you is only one aspect. And I blame the manufacturers. They sell these vaccines to say, hey, you want your daughter to be protected from cervical cancer? She should get this vaccine. You want your son to prevent him getting a meningitis when he goes off to college? He should have this vaccine. There's something much bigger about vaccines. You know, we eliminated smallpox and polio because of vaccines. And that's something that everybody benefits from. And so in this pandemic, when you're making life choices, especially with COVID-19, when there's asymptomatic, pre-symptomatic spread, the decision to or not get a vaccine is not going to affect just you. It's going to affect those literally that are closest to you as well. And as I was telling in the breakout session, we're making decisions this morning in our intensive care unit. Who's going to get dialysis? Who's not going to get dialysis? And these are people that had nothing to do with the decisions that were made 3 weeks ago when we had family gatherings without masks. Those decisions that were made by people that were not involved are now coming home to roost. And these people who are underrepresented, who are not, had nothing to do with that decision, are now paying the consequence of that. And so there's a big decision here. And I bring that up because when Ellen G. White apparently was asked whether or not she would receive a vaccine that never went through FDA approval, that didn't have thousands of people in a study, she not only took that vaccine, but she also instructed those working close to her to get that smallpox vaccine as well. And so I would invoke Romans 14 in your thought process about whether you choose or not to get the vaccine.
Thank you very much, both of you, for answering that question and really bringing up the issue of our, may we call it our social responsibility. But this was actually going to be my closing question for today. I'm going to bring it up now because we're talking really about the mission of the Seventh-day Adventist Church. Most of us in attendance today are members of the Seventh-day Adventist Church, and the mission of that church is that related to this about promoting the health and safety, not only of ourselves, but of those around us. Any comments on that, Dr. Williams or Dr. Seheult?
I think it's we in our health ministry, what we are seeking to do is to follow the example of Jesus. Jesus mingled with others as one who desired their good. He manifested an interest in their affairs. He ministered to their needs. He won their confidence. We're told that there were entire communities and villages where no one was sick because Jesus had passed by. Jesus addressed the health problems of his day. We are following in his footsteps. We need to make the love of Jesus real by ministering to the needs of others in our community. And that gives us responsibility in the midst of this pandemic. Again, a pandemic that is right now killing more people than heart disease and cancer on a weekly basis. Yes, we can, there is a lot that we can offer to our members, to our community, by providing them information and resources in terms of dealing with this pandemic. And I love what my Dr. Roger did in terms of talking about vitamin D and talking about what we can do from a prevention point of view. And I don't think it's either or. Both. Let's do all that we can and share that good news with others. It's a way that we can meet the needs of people who are hurting and who are open in our community to learning more.
Thank you so much, Dr. Williams. Now, Dr. Seheult, you did talk quite a bit about vitamin D, about hydrotherapy. You have spent many, many hours discussing those in other videos. Can you just share with us, someone asked the question, well, how much vitamin D should I be taking? Is that something that you can advise us on today?
Yeah, so I'm nobody's physician here. I'll just start off and say that, but I can give you some guidelines. The Society for Endocrinology has put out recommendations that if you wanted to supplement, if you believe you are at risk for having vitamin D deficiency, and who are those people? Generally, people who live above the 35th parallel. That is, for those of you who don't know, that's the southern border of Tennessee. And for us in California, that's sort of runs right through Southern California. That's a pretty low line. And anyone who lives, obviously anybody in Canada would fit into that category. So you're not getting enough vitamin D in the wintertime. The sun is just too low. And so you're at risk for having vitamin D deficiency. Who is at increased risk? People who are older, people who have dark skin, because it takes more ultraviolet B radiation to come through. If your shadow is longer than you are, then there's a good chance you're not getting enough sunlight at that time to get ultraviolet. So if you are at risk, the recommendation is 4,000 international units daily. without physician supervision. If you wanted to do more than that, then you could go ahead. Probably the best thing to do, though, is if you're concerned, is just get your level checked if you're able to. It's a 25 hydroxy vitamin D level. And the target that I would like to see in myself personally is about 50. That's where, according to the studies that we just showed, that there is an increased risk of SARS-CoV-2 positivity once it drops below 50. You know, a lot of studies have been done on this over the years. They were looking at vitamin D and calcium metabolism. And of course, we know that we need a certain amount of vitamin D for proper calcium metabolism. I don't think the studies have really looked at how much vitamin D we need for good immune system functioning. And so I think right now, we certainly don't have available vaccines for everybody. And the vaccines are only going to be beneficial for SARS-CoV-2. They're not going to be beneficial for the flu or for other things. Let's work on all of the above. You know, as Dr. Williams says, it's an all of the above. It's not an and or either. So increasing vitamin D levels are beneficial. I take 5,000 units a day. I know of people that take 10,000 units a day. They've had their levels checked. They're not toxic. Vitamin D is probably one of the most safe fat-soluble vitamins there is.
Thank you very much. And as we get further questions about vitamin D, again, I want to encourage you, as Dr. Seheult also said, please talk to your physician, find out what your levels are and get their advice on what you should be taking and what your family members should be taking as well. Now, Dr. Seheult, we've heard again in the news that there are actually some healthcare workers and maybe even first responders who are deciding not to take the vaccine. What are your thoughts about that? What are their reasons behind that? And what's the message we should take away from that?
Well, it's because they're subjected to the same media and things that we are. So it's kind of discouraging because every single allergic response that has ever happened from getting the COVID-19 test has been on the news. And yet, if you were to do that with penicillin or anything else, you would just be reporting on allergic reactions all day. And so you've got to look past the drive-by shock media to see exactly and dig down into the numbers. Here's the problem. This virus has crippled the economies of multiple industrial powers in the world. And the industrial powers of the world are trying to seek an opportunity to gain a foot on one another. And so there has been a massive amount of disinformation, misinformation, sowing distrust coming from other countries around the world and injecting that into the conversation here in the United States. We know that this is happening. Have you ever logged on to a website or wanted to leave something and it asks you to click a button that says, "I am not a robot"? That's the reason why that's there, is because there are thousands of bot computers that are leaving messages on multiple YouTube channels and social media that is trying to inject false information, scaring, so that people in the United States don't get the vaccine, that the coronavirus lingers on. And here we are, as Dr. Williams has said, we're the number one. We are where it's happening in the world. And that is also somewhat because of our dietary choices and our lifestyle choices, but it's also because of the fact, and it will be because of the fact, that we don't have a vaccine. We don't reach herd immunity. If we don't reach herd immunity, we will not reopen as a country for business. And that will be very beneficial for our competitors around the world.
Thank you. And Dr. Williams, can you talk to us a little bit more about this herd immunity then? What do we need to get to? Where do we need to be?
We don't know the specific number, but the concept of herd immunity is when enough people are protected that the virus no longer spreads in an epidemic fashion. Doesn't mean that there's absolutely no transmission, but no large scale transmission. And most experts usually put that number as somewhere around 70 to 85% of the population being protected. And in theory, you could get protection from some viruses through natural immunity. And there's a question mark about whether, if you got it, the COVID-19, whether you are protected or not. We don't know for sure. And then the other thing will be certainly getting the vaccine. And one of the questions that still is out there, because we have only 2 months of follow-up for the data that we have so far, we do not now know how long the protection that individuals will get last. And will it be something like the flu, where you need to get a vaccine every year? We do not know that right now, but there's ongoing studies gathering that information, so you know that we will have a better sense of that. But the basic idea of herd immunity is that we are getting to a high level of a proportion of the population being protected. And again, I think it's about being a good neighbor, is thinking not only about yourself, but thinking about others. You're helping your family, you're helping the community, you're helping your country when we get to herd immunity.
Thank you very much for that. And referencing the science and how our knowledge and our understanding of the situation will be increasing probably pretty rapidly over the next few weeks and months. Now, Dr. Seheult, you recently did a video on your MedCram series where you talked about the scientific process, and you mentioned that early on in the United States, even our government officials were saying things that, well, masks were not really effective, we weren't going to require them, but they changed their mind later on. Was that because they just didn't, I mean, what happened there? What can we learn about the scientific process as we consider continuing to live in this pandemic for several more months?
Yeah, so some of the reason why they changed their ideas were scientific based, and some of them were a little bit more nefarious, unfortunately. There was a real fear that if they said that masks were the way to go, that all the masks would have disappeared and there'd be none for healthcare workers. I think that's been admitted to. But deeper down, they also felt that this virus was going to be airborne, then simple masks would not be beneficial. And that's actually true. Simple masks like the cloth masks that people wear, if it was only by aerosolization, then it wouldn't be effective. But the fact of the matter is that this virus is transmitted in many different ways. One of those ways is aerosolization, but another way is through large droplet. And the fact of the matter is that masks are 99.9% effective at preventing large droplet transmission. So that means if you're not in a closed space, if you're coming into close proximity with somebody for a short period of time, masks pretty much can 99.9% reduce the main way that coronavirus is transmitted. Now, that doesn't mean that it's necessarily good in an enclosed space, and that's where ventilation is very important. And that's why in the hospital, when we have patients in negative pressure rooms pumping the air out through filters, the transmission rate there is very low. As we talked about on airplanes, it's very low because of ventilation.
Okay, thank you very much. And really the science is changing. What we're learning continues to grow. And it's really important that we continue to keep in touch with valid and reliable information. Can you both share with us, again, you mentioned some of the resources in your presentations. Can you just remind us again, what are some of those places where we can go to find additional information about the coronavirus, but also vaccines specifically? And Dr. Williams, we'll start with you.
Oh, I mean, some of the sites I recommended on the CDC website, there is good information there. And I would just emphasize one of the points when it comes to the COVID-19. It is true that some of the information has changed over time, and as Dr. Rogers said, part of that reflects the evolvement, the development of the science. You know, at the beginning, we make the best decision with the knowledge that we have. And this was a new virus. We didn't have a history of studying it for decades. So as time has gone by, we learn more as it's being studied in other countries, and some information becomes clearer over time. So I think some people think that whenever there's a change, there was something problematic that occurred, not necessarily. And I think, Dr. Roger, you're right. There are many reasons. I think Dr. Fauci himself said he didn't want everybody running out and getting the N95 mask, and that he wanted those to be reserved for frontline healthcare workers. So that is true. But I think in general, I think people are responsible. So WHO website, the CDC website, and I mentioned some university websites that I was aware of, both the Harvard School of Public Health, the Harvard Medical School. I talked about Johns Hopkins has a great COVID-19 resource site as well. And I certainly would put a plug in for the Amen site and the other sites that Dr. Roger talks about. It's good to have good Adventist sites that balance the prevention as well with the other information as well. And from some of the other sites, you don't get it. You get the basic facts of the science, but not the emphasis on prevention.
Thank you. And Dr. Seheult, anything you can add to that list?
Yeah, I mean, a good example is actually somebody from Dr. Williams' school, Dr. Allen, who's been advocating for ventilation and turnover of airs, even monitoring it through carbon dioxide detectors. The CDC must be listening now, because just recently here in December, the CDC updated its website to fit actually a lot of the recommendations that Dr. Allen from the Harvard School of Public Health has been advocating for and talking about. And so he had a nice interview on the Harvard School of Public Health web channel about a few weeks ago that went through that and actually encouraged people to look at that, because it's important. Sometimes people have loved ones at home who are COVID positive, and you're trying to reduce transmission within a household. What do? There's some ideas there: cracking the windows open, realizing that it's the winter time, increasing ventilation, still wearing masks. These are all things that can reduce transmission within a household. So that shows, I mean, it shows that things are changing. I would be very concerned if things hadn't changed. So when I see recommendations being updated, that's a healthy thing. Science is learning all the time. And when we have organizations that can change with the times and come up with ideas and change their recommendations, that tells me that things are working. Not that things are not working. Nobody's perfect. We're never going to get it right 100% of the time. When you graduate from medical school, they shake your hand, they give you a diploma, and they tell you, as you know, Angie, great, 50% of what you just learned is wrong. We just don't know which 50% it is. You'll figure it out. But yeah, this is normal. This is par for the course. This is exactly what I would expect.
Absolutely. Thank you so much. We still have a lot of questions left, but unfortunately we are out of time today, and we've already gone over by several minutes. And I want to be respectful of your time. Again, we are going to be posting the video of this presentations on our website, NADHealth, HEALTH.org/ministry goals with an S. And we're going to try to get that up there in a matter of hours for you, as well as the links and the resources that have been mentioned today. But, you know, we want to remember, as we leave this space that we've shared together, one of the things that we can always do is have an influence. And the question for each of us to consider, will that be an influence for good? Will we share hope and wholeness? Christ came to give life and life eternal to others. We have an opportunity to help others find resources, both through prevention as well as care, to have life here on this world, but we also want to remember the life to come. We want to encourage our communities with that hope. So I want to thank you all for being with us today. We still have so much to discuss. We hope to have the conversations continue in the North American division, and we'll be putting out information as we have that. But I want to especially thank Dr. Seheult, Dr. Williams, for sharing your time with us, your passion for this, the expertise that you've gained, and reminding us again that we are all in this together. And the test for us is that will we want to come out on the other side also together? So let's keep that in mind. Thank you all again. I'm going to ask Dr. Williams if you would close us out at this time with a word of prayer.
Thank you. Father in heaven, we thank you that in the midst of everything that's happening in our society, we have a Father. We can call you our Father. And you know that even though you manage the affairs of the universe, you care about everything that happens in our lives, and you love us and you care for us. We thank you for the opportunity we've had today to learn more about health and learn more about how we can be a blessing to our churches, our communities, our schools, with the knowledge and information we have gained and that you want to share. We thank you, Lord, that you came that we might have life and have it more abundantly. I pray your blessing, your richest blessings on everyone within the sound of my voice and in their families, that they will go back with new information that they can share and that can help others to find a more abundant life, not just beginning with physical health, but then lead into spiritual health and a closer walk with you. Keep us in your care and keeping, and give us the fullness of your spirit that we can represent Jesus, not just with the facts that we have, but with the love that and kindness and compassion that is present in every encounter we have with any of your children. And we will give you the glory, the honor, and praise in Jesus' name. Amen.